The first, hi Hyman, is PrEP. And Hyman Scott is a faculty member at UCSF, as he mentioned earlier, is primarily based in the San Francisco Health Department, which I think along with the New York Health Department, people are among the most forward-thinking in the country. Hyman is from Chicago. I think fair to say helped raise his younger brother on the South Side. So Hyman, tell us about PrEP.
You going to stay up here? Okay. Thank you, Paul. And it was actually my younger sister, and she came to live with me during intern year. And so I think Paul, she came to the hospital with me a bunch of times. She's a big volleyball player, even though she's 4'11". She was a good setter. So I'm going to talk about PrEP, and happy to take questions as well. So as Paul mentioned, I'm in San Francisco. So in addition to these roles I'm also the medical director of the Struck Clinic, which is a sexual health clinic based in the Castro. We have about 3,500 people on oral PrEP and just a handful on injectable PrEP. I have no financial disclosures. These are the learning objectives, talk about the efficacy of the PrEP trials. I'm going to spend a little bit more time on injectable CAB, and then talk about management of discordant HIV test results for patients who are on PrEP. So I have a few ARS questions. So this first one is a 31-year-old cisgender MSM with a serodifferent relationship with an HIV-positive partner for 2 years. His partner is only occasionally suppressed, so your patient will like to start PrEP. He has outside partners, which he refers to as guest stars, and reports that he uses meth almost daily. He's on a depression medication, which he has okay adherence to, taking 1 to 2 days a week. So would you give him oral TDF-FTC, oral TAF-FTC, on-demand TDF-FTC, or an injectable option? All right. So more than half would offer CAB-LA, and about 20% one of the daily oral options, and then on-demand TDF-FTC. So I'd say I'd probably agree with that. I always say the best PrEP regimen is the one that somebody's going to use. So I would focus on what they would want to use. So now we have updated guidance in the CDC from the 2021 update that essentially said that PrEP should be offered to all sexually active adults. None of this figuring out what people are doing. Talk about if someone is having sex, then PrEP should be offered to them. And we have a menu now. So these are broken out by the populations in which they've been studied. Some of us make extrapolations. For example, trans men have been systematically excluded from many of the studies, but we don't exclude them from essentially oral TDF-FTC. So for what I'd like to focus on is each of the regimens. So for daily oral TDF-FTC, that's essentially for all populations in the absence of any severe renal disease. I would say creatinine clearance less than 60. TAF-FTC is approved for individuals who are exposed to HIV through sexual risk, with the exception of receptive vaginal sex, and has not been studied for people who inject drugs, which was pertinent to the last discussion we had. On-demand PrEP, it's been primarily studied among cisgender men. There were trans women included in the studies of 211, which are predominantly in France and French-speaking Canada. But when you look at the data, there are actually very few trans women who are enrolled in those studies. It's on the order of 5 to 10. But we still offer it as an option, given that it's often exposure through rectal sex. We have no data on neovaginal exposure and how 211 would work for those women. And then CAB-LA, which I'll spend a little bit more time talking about. is again sort of got the broadest spectrum, except for people who inject drugs. And to the point that was asked in the last presentation, a lot of the people who acquire HIV in our communities are through sexual exposure. So we do not exclude individuals who are currently actively injecting from injectable PrEP, if is what they want. And daily oral PrEP, there's a lot of discussions about how well it works and if it works. These are just a slide from AVAC. And just pointing that if you take it, it works quite well. I'd like to point out the two dots at the lower left, the blue, light blue, and the dark blue that's closer to the line. Those were the VOICE trials among women and looking at TDF-FTC, where we actually saw a negative efficacy. And so there were more infections in those who received TDF-FTC. A lot of this is driven by adherence, as we know, but there's a lot of data. There was some data presented at CROI, which I'm going to highlight, that really supports the idea that we should be offering oral TDF-FTC to cisgender women in the same way we offer it to cisgender men, without all the caveats. So Jeannie Marazzo presented these data from demonstration projects, which looked at a large number of cisgender women from across the world, and looked at both objective and subjective measures of adherence, and they broke these into different categories. So those who were consistently daily, consistently high, those who started high but then declined later, and those that were persistently low. And they had a fairly large number of participants who were in each of these categories. And then they looked at, based on these objective measures of adherence, what was the HIV incidence among those individuals. And what they saw was that when people were taking it consistently daily or consistently high, that HIV incidence was quite low. In the past, I think we have always said that for cisgender women, for HIV prevention, taking it 7 days a week is really essential. I think these data support that maybe there is more forgiveness to the daily regimens of TDF-FTC in the way we talk about it with men who have sex with men that are reflected in these data. So I think this is sort of supporting the idea of offering it and supporting women. There are few HIV diagnoses in these analyses, but I think it is pointing us in a direction that's different than we had been in the past. And so I think there'll be more data coming out about this that will hopefully support sort of continued messaging around supporting cisgender women in daily oral TDF-FTC. CAB-LA is superior to TDF-FTC in two large clinical trials, so HPTN-083, where the efficacy was 66% compared to daily oral TDF-FTC, and then in 084, which was a study of cisgender women in sub-Saharan Africa, where the efficacy was even higher, likely driven for both of these efficacy endpoints by lower adherence in the TDF-FTC arm based on objective measures and DBS subsets. At CROI, there was also 08401 that was presented, which was among adolescent girls, focused on safety, to expand the indication to be inclusive of that population, and there was no safety concerns, and individuals liked having access to the injectable option for a variety of reasons, including privacy, ease of use, and not having to take a daily pill. We also presented some data at CROI of a sub-analysis of HPTN-084 that looked at in the US MSM population the incidence and efficacy among Black MSM in the United States and transgender women, which accounted for about 50% of the population in that study. And this data, I think, is both sobering and also enlightening. So in the arm in which they received TDF-FTC, incidence was still 2.11%. That is a very high incidence in a population in a clinical trial that is, has access to PrEP without cost. And so there are 15 infections in that group, and there was 4 infections in the CAB-LA arm. And so there was a very large difference, 72% risk reduction in acquisition in that population. When we looked at the non-Black US population in this study, there were 5 infections, so starting out in a PrEP population, this is sort of what I think we're starting to see in demonstration projects, this incidence of about 0.63. In the CAB-LA arm, there were 0 infections for a hazard ratio that was 0.086. But I really think that this highlights that we see these massive disparities in HIV in the US among Black MSM and transgender women, and that this tool might really have a really important role in trying to address some of those disparities. There's a bunch of issues with CAB-LA that are structural, which I'll talk a little bit about, but as far as whether or not this works and can work in the way that we want it to for equity, I think that this is a tremendous opportunity for us to use it. The menu of PrEP options is expanding. Some of these things are moving forward and some are not. There was a presentation of a drug-eluting device at CROI that can elute over the course of potentially 6 months or more and can stay in the body and be refilled for as up to 20 years. Islatravir as a PrEP agent is no longer moving forward. Hopefully we'll have an alternative. And we have lenacapavir, which is in a phase 3 trial, which is ongoing. So hopefully we'll have some of those data as well. We've learned quite a few lessons from oral PrEP implementation, and that even with this data about how well it works, in the US, only about a quarter of the individuals who have an indication for PrEP are taking PrEP, and that we have these massive racial, ethnic, and gender disparities, both in who starts PrEP and then who stays on PrEP. So these are some data from our primary care clinics in San Francisco, which show that Black patients were less likely to stay on PrEP and were to discontinue earlier than other racial ethnic groups in our clinics. And we know that the incidence goes up quite quickly once someone stops PrEP. We've learned a lot about the challenges. So what I wanted to highlight from this slide is just that when we're doing PrEP, you realize how much changes we need. So around staff awareness. So for those of you who are doing PrEP in your clinics, you know, our patients encounter not only us in their clinical flow, but they also encounter the front desk staff and the nursing staff. And so having staff that are saying that we don't do PrEP here is problematic, even if you are pushing it as an option for someone to take, and that's something that we've seen quite a bit. Particularly for CAB-LA, there's a heavier lift on what the clinics need to be able to do to implement, so having the capacity to do that, and then having providers who are willing to offer it. And then we underestimate as providers the financial implications of PrEP, particularly when individuals go to the pharmacy and are told they have a huge copay, and then their decision is just to not pick it up and not to tell us. So I've had 3 new HIV patients come in who have told me that story in San Francisco, where PrEP is quite ubiquitous and quite easy to get, but it's still a challenge and a threat to our efforts to sort of end the epidemic, both locally and nationally. And people are really interested in these non-daily options. We had the first data on daily PrEP, but people want other things. And I think contraception has given us insights into this, and so leveraging some of what we've learned from contraception, you know, in this Australian study of PrEP-experienced MSM, the majority preferred a long-acting agent, up to 60%. And in the US, it was slightly less, but in this study in the US, where long-acting injectables were at 25%, when you looked at those who reported condomless receptive anal sex, it was actually the long-acting injectables that had the majority of interest. So thinking about matching people's interest with the risk that they are reporting, I think is going to be a really important part of how we roll these options out and how we make them available when we finally have access to them. This is true for women as well, and so this was a study from an HPTN 076 study, which showed again that there's a lot of interest in these long-acting agents, and that individuals are more likely to take what they, when they're given a choice, they're more likely to take what they're prescribed. So this was a study from the MTN 034, where they moved from a ring to oral PrEP, and then after the initial phase of the study, they gave the women a choice about what they wanted, and when their product matched their choice, they're more likely to take it, which seems quite intuitive, but I think really getting to this point of offering it and providing tools for people to make decisions and then helping them stay on it is going to be really important as we have this expanding menu of options. these are some of the ways that I think about these options. So for TDF and TAF-FTC versus CAB-LA. So some of the pros of the oral medications are really about implementation, access. Now that TDF-FTC is generic, it's quite cheap through 340B pricing. Some of our clinics can get it for as cheap as $4 a bottle. So it's cheaper than a lot of our STI screening that we're doing and some of our HIV testing. There's quarterly testing that's required. You can use rapid testing to monitor people on it. And then it does require daily adherence or a complex 2-1-1 regimen. So that is probably the biggest downside. For CAB-LA, I think efficacy is one of the biggest pros, but I also point out that efficacy is not the criteria that a lot of our patients use for deciding what works best for them. And so even though this worked better than TDF-FTC, it might not be better for our patients. Doesn't require daily adherence, but it does require more clinic time. So having staff and space to be able to do the testing, and then we really don't understand why these breakthrough infections occurred in the trials, despite high levels of adherence, on-time injections, and PK that would have suggested that those individuals should have been protected. And we didn't see that in our TDF-FTC trials, and so it's still really an open question. And I also like to highlight in 083 where there were these subgroup analyses that CAB-LA was associated with lower incidence among all the populations that we have in the United States, in particular where we're seeing high HIV incidence and large levels of disparities. So this is sort of reiterating the idea that this is a really important tool for the populations that we most want to get prevention to. And then there's some clinical considerations. So for HIV testing, point of care testing in healthcare sites, viral load testing is expensive, and in some of our primary care clinics in San Francisco, we actually struggle with getting it done for the courier reasons. You need more staff and more places to be able to do the injections. Most places are not able to do same-day starts, I think mostly because of the financing aspect of it, but it really doesn't allow you to streamline in the same way we can do with oral PrEP. And then how do you cover missed injections? I have a couple slides that sort of outline what we're doing for missed injections. It sort of differs from what the FDA label and package insert suggest, but also what do you do with PEP regimens if someone misses a dose and has an exposure and you want to manage that potential exposure for HIV. This is a list of all the pharmacies that do buy and bill and the medical or pharmacy benefit for CAB-LA. So as I mentioned, TDF-FTC is about $4 a bottle, whereas CAB-LA is $3,700 per shot. And so there's a lot of insurance companies that are pushing away from this, requiring prior authorizations and just outright denying it. I think the other aspect of this is that for those of us who either work or collaborate with community-based clinical sites that are not in-network, then there becomes additional out-of-network costs for individuals who are on an HMO. And so even though it might be covered in an in-network provider, if that provider is not offering this option, then you can't use it outside of that network. So that's come up a lot with our patients who are trying to access it. There are some assistance programs. We're pushing the manufacturer to raise this to $9,000, seems to be the magic number in California for out-of-network costs. So we're trying to lobby to get that amount covered for out-of-pocket expenses so that we can expand access. So missed doses come up quite a bit because we saw this actually in 083 quite frequently. We had a young mobile population, and this is even before COVID. People would miss their doses. So the FDA label distinguishes individuals who have a planned and unplanned missed dose and suggests covering that with oral CAB if it's less for up to 2 months. And then if it's unplanned, regardless of whether or not it's 4 weeks or more, I think 4 weeks cutoff is really an important number. In 083, we actually used 8 weeks, so it wasn't late if somebody up to 8 weeks after it was due. And then reinitiating with a loading dose. So what we actually do is we don't care if it's planned or unplanned. If it's missed, it's missed. But if it's less than 4 weeks, we actually don't consider it as a missed injection. And so there's a 4-week buffer for individuals. So 1 week before it's due and then up to 4 weeks afterwards to give people flexibility so that we're not having them come in and get reloaded or sort of undermining by asking them to take other oral pills when we're identifying people who might have trouble with oral pills. And so we just say if it's less than 4 weeks, it's not late. You just have come in at a different time. If it's more than 4 weeks, then we reload individuals. And we give everyone TDF-FTC or oral CAB for them to take, for example, if they're traveling or something and they need to cover doses, and we ask them to just take that immediately after they miss their dose. And if they're traveling and have an exposure and they have TDF-FTC, we actually instruct them to just start that as a PEP regimen so that they can come in and get tested. So happy to take questions about that. The other piece, we talked a little bit about this, is the PK of CAB is quite different in people who are assigned male at birth versus female at birth. So it has this very long tail, as many of you are aware, but it's actually quite longer, up to 6 months longer among people who are assigned female at birth. So we had some discussions actually during one of the breaks about the implications for this during pregnancy if somebody were to become pregnant and were to continue on CAB-LA, both for HIV prevention or were to stop, and what the implications would that be for both pregnancy but also for breastfeeding or chest feeding of an infant after someone has received CAB-LA. So it lasts a very long time in the body, and there are people who have detectable doses, if you look at those ranges, up to 52 months after they stopped injections. So it can be in the body quite a long time. So how do we talk about discontinuing? So really talk about covering and the declining CAB levels. We counsel people about ongoing risks for and indications for PrEP because we do see this high incidence of people who discontinue PrEP. So we usually prescribe daily oral TDF-FTC after the point at which they're sort of no longer protected. CDC guidelines recommend quarterly RNA testing for a year after discontinuation. I will say in the studies 083 and 084, in which there were quite a few infections that occurred among people who had discontinued or missed injections, we didn't see CAB resistance in those individuals. It really occurred when people received their injections and had an unrecognized HIV infection. So we really focused on the tail, but the tail didn't represent the bigger problem I think we identified in the trial. It was people who had these unrecognized infections before we gave them their next dose. And in that study, there was viral load testing was done retrospectively, which is why the recommendations now are to do RNA testing. And by giving those injections, we really delayed seroconversion substantially. And so it was about 98 days in incident cases. So this is about 3 months. So it could potentially have gotten 1 or 2 additional injections. And in baseline cases, it was up to 2 months for the CAB arm. And this really wasn't something that we saw substantially delayed in the TDF-FTC arm. And that, as I mentioned, the major resistance were detected usually in cases where we continued to give injections without recognizing that somebody was HIV infected. At CROI this year, Sue Eshelman presented on the new syndrome that is called Levi syndrome. So it's long-acting early viral inhibition, and she outlined in a comparison to acute HIV infection. And so essentially the major differences are this is a long, smoldering, difficult to detect infection versus the sort of explosive acute HIV infection that can occur. And this was in one of the panel cases as well. It looked more like an AHI, which for me suggests lack of adherence. But in Levi, it really is difficult, and using an RNA assay and using a different assay with the lowest feasible viral load that you can implement, I think is most important. And then another component of this is that you do have variations in the antibody response. So there might be cases where you serorevert between tests, and so this can be quite difficult to identify. All right, so we have another ARS question. So this is a 35-year-old MSM in a serodifferent relationship, comes in seeking PrEP. He states his partner has been unsuppressed and just started a new regimen because he thinks, he said, there was something about M184V that required it. So he doesn't like condoms, they're not an option. So what would you suggest? Condoms until the partner is virus suppressed, TDF, FTC, TAF FTC, 3-drug PEP. He reports sex with the partner 2 days ago, and there's something else. So I think the majority of individuals suggested 3-drug PEP, and that's generally what I would agree with. And we often do a PEP to PrEP transition, and it's one of the points we make with our fellows when we're teaching them about PEP is not to forget about the option, or talking to them about PrEP is not to forget that PEP indications are often present for our patients at the time of PrEP initiation. We do want to try to make sure we cover individuals. This is a summary of PrEP breakthrough infections that have been reported, and this is actually what I use when I'm counseling my patients, is that, oral PrEP, if that's your choice, works really, really well. That there are breakthrough cases, nothing is 100%, but it is case reportable. So these are some of the case reports that came through with PrEP breakthroughs in oral TDF FTC, and one of the common themes is the M184V. So it is something that if there is a partner who has a known M184V, and that's the only partner, which is often not the case, to be honest, that if the partner is not virally suppressed, then we might use a 3-drug regimen or use CAB-LA in that setting. And then also just the U equals U, and keeping in mind for all of our patients, if they're guest stars who are present in their sex lives, that we need to cover them for all of the potential exposures they might have. All right, so I think this is the last ARS question. So this is a 31-year-old patient who comes in for a routine quarterly lab test. They're on oral PrEP. The 4th-gen antibody test is positive, but the confirmatory test and the viral load are negative. So what would you do? Would you repeat the test but continue PrEP as you assume it's a false positive? You repeat the test and stop PrEP but start ART for acute HIV infection. You repeat the test and stop PrEP until you can determine what their status is, or something else. Threshold. All right, so, this is great. Okay, so 40% assume that the 4th-gen test is false positive. 34% would repeat the test and stop PrEP. And, well, it keeps changing on me. And then 18% will repeat the test and stop PrEP. Okay, great. So I don't know that there's a specific answer. It's just I have an answer that I would probably prefer, and I'll talk through how we make those decisions or how I approach those decisions. So this is just a reminder that early on you're going to see a viral spike, and then you're going to sort of get progressive antibody responses in the setting of acute HIV. And so how do you think about like what you do when you get this result? So we have our quarterly or now bi-monthly testing in the setting of CAB-LA, and you get a discrepant HIV test result. So your goals are really to determine if this is a true infection or a false positive. And just a reminder, viral load tests have a higher false positive rate than an antibody test. So you might be in this position more with CAB-LA. So you confirm the presence or absence of infection, you repeat the serologic RNA test, and then a key point is try to use a test, if possible, from another manufacturer or a different type of test, so you can see if you get the same result across 2 different platforms. And then you have to decide what you're going to do with the antiretrovirals. So you have 3 options. You can continue the PrEP if you think that they're adherent and it's a false positive. You can stop PrEP and reassess their HIV status, or you can start ART. So if you continue PrEP and they're adherent, and they actually do have HIV, you're going to risk resistance, of course. But if you stop PrEP and it might allow you to reassess their HIV status, but if they have ongoing risk, they might actually acquire HIV during that period in which you stop it. So it is not without its risks, even around assessing HIV status. So it's really important to engage your patients in if you decide to do that. I sort of consider that a structured treatment interruption, and I would approach it with the same care as you would do with patients living with HIV. And then if you start ART, if they're not adherent, you might have more difficulty deciding and figuring out if somebody actually has HIV. And so those are some of the options and the associated challenges with them. I think the drug-related AEs with starting ART are less of an issue now with our regimens. If you need help, there is a PEP line, the PrEP line, which was started through the clinician consulting service, and so this is their number. I'm one of the providers who's on the line, but we get some really interesting cases from clinicians and are always happy to talk through how to approach managing them. So I'm just going to stop there, and thank you for your attention. I'm happy to take any questions.
Stand up here. So super, and I liked how you kind of were going a little bit into PEP at the end, because that's an anticipation of the next talk.
Yeah.
While I was sitting here, I was kind of working with or playing with this tablet that we have to ask questions. No one's using it. But I asked a question. I said, is TAF better than TDF in PrEP? Just to put something on the screen. Spell check said, is TAD better than tofu in PrEP? I don't think anything's better than tofu in PrEP. But the Levi thing reminds me that I heard a talk just last week that Bob Gallo, remember him, gave, where he's speculating. Steve Deek said he agreed with it, which makes me worry because Steve likes to be contrarian, that elite controller is not a specific thing, it's just a function of dose of infection. And it strikes me that maybe, if that's at all true, that these cases of infection while on PrEP might reduce the dose long enough that these people might end up having kind of the equivalent of an elite controller. I don't think there's any data, but if you want to comment, it'd be...
Yeah, I mean, I think that there was clearly still ongoing replication, because a lot of these individuals acquire new mutations and INSTI-specific mutations. So I think, yes, that might be true. And if there are ongoing risks for HIV, then they want an agent to, if we don't know what their HIV status and they continue to get antiretrovirals, they're going to just develop more and more resistance. So, I think that we didn't do there was no structured treatment interruption for those individuals. I think that might be a sub-study that might sort of evaluate to see what type of viral rebound they would have if you stopped therapy. We did that in the AMP study to look if it changed the viral set point and made individuals more like elite controllers. So I think it's an interesting question, and it would be an opportunity to do that prospectively.
And then you mentioned the one risk of stopping while you're kind of sorting out which might be a false positive test result is that the person might, if you stopped PrEP, you might acquire HIV, but the other risk, I guess, would be if it's really like an ATI and they actually are infected, then during that time they might actually rebound and transmit the virus too as another risk to be considered and discussed with the patient. But
Absolutely. I mean, if they have acute HIV and have a viral load that spikes to,
Right.
500,000 or a million, there's an onward transmission.
Yep.
And, I think from the counseling standpoint, I think bringing in partners, but starting with their health and what it might mean for them, and then including the partners and the risks to their partners as well.
Yeah, I
But
mean, I think
absolutely.
one of the themes today has been kind of being overly attentive to including people that are involved in the decisions that we sometimes think we're making for people. But,
Yeah.
Yeah. So a question about low level of viremia while on ART. We think we have a sense that high viremia translates into high risk of transmission. Low equals low. What about those people with very low levels of viremia? What do you tell them about their risk of transmitting? Does that come into your consideration with some of these approaches?
Yeah, so if they have a partner who's like at a blip or a viral load that's less than 200, I sort of use the data and talk to individuals about the risk of acquiring HIV from their partner. And, I think some of the epi data we've seen prior to sort of U equals U is about 30% of HIV acquisitions come in the setting of primary relationships. So really understanding if individuals have, other people who are involved. And there were a lot of infections that occurred in these trials. They just didn't come from the primary partner who was
Right.
vitally suppressed.
So when I was sitting over there, I was kind of helping monitor somebody standing at that microphone.
It's hard to
but when
see,
you
isn't
stand
it?
up here, it actually is hard to notice. So, at the mic. And a reminder to feel free to use the microphones. Yep.
And so I do a lot of PrEP and HIV care for youth age 13 to 24. I have a lot of my patients that have a lot of needlephobia and are ambivalent to do Apretude at this time. So for my patients that are on the younger spectrum, are we concerned really about that bone mineral density with the TDF-FTC for the patients that can't take other options because they're assigned sex at birth?
Yeah, we get that question a lot. So, the bone deposition sort of ends around age 25, and so we really don't know if and to what extent it matters if there's a slight decrease in bone mineral density in the setting of TDF-FTC. It becomes an informed choice that individual would make. Like if someone acquires HIV and goes on HIV therapy, we're going to be also potentially exposing them to one of those medications. So, and I also think it's important to think about, these DEXA scans were not designed to be looking at bone mineral density in 17-year-olds. And so there are some limitations both in our assessments. So we take the approach of offering it and sort of making the calculation that acquiring HIV would be more risk to their health than potential bone mineral density changes where there has not been association with increased risk of fracture, even if we see a decreased bone mineral density in the DEXA scans.
Yeah, a lot of my colleagues are starting to provide like vitamin D supplementation to these patients just to give them like another piece of reassurance.
Just in case.
Just
Yeah.
in case. But it's just something that's come up because at least in our area, we're seeing a lot more commercials. If you've been exposed to the drug Truvada, the bone mineral density and those type of things. So I think we have that fear from the patient, do I take something that can possibly damage me, It's a really tough case that we're dealing with a lot of our youth that are still a little bit ambivalent about the Apretude.
Yeah, and I think if you have access to TAF-FTC, like I think Paul was asking, he put into was that Chat GPT? But that's another reason where I would sort of offer something else because honestly, if that's what they're telling you, like I worry that even if they say yes now, it might impact their ability or desire to continue it. So I try to roll with that and offer them things that they would really want and would allay their fears about it because it is something that for the extended period in which they're at risk for acquiring HIV, we sort of really want people to use those options and sort of matching it with what they are saying that they want.
Thank you.
Great, thank you. Really quick, given the time, is lower efficacy of TDF-FTC versus LACAB just a function of adherence? Is there something inherent about the medications?
I don't think that there's anything inherent. I do think it's likely driven by adherence. and that the fact that adherence was so much higher, if you look at the adherence to on-time injections versus sort of the dry blood spot subsample that was in those studies, overall it was about 74% for TDF-FTC, where it was over 90% for CAB-LA. So I really do think, I don't think we have any pharmacokinetic data that would suggest why that would be worse.
And then finally, can daily be done, or on demand be done with Descovy, the TAF version? And what about in cisgenders? Yeah.
In cisgender women or men? Cisgender women?
Both.
Yeah, okay,
Either.
fair. So there are no data looking at, clinical data looking at on-demand or 211 with TAF-FTC. I think the PK data suggests that, that it should work. And so there are scenarios where we might offer it to individuals if that is really the only thing that they really want to use for prevention, but it's a data-free zone. The PK would be supportive. And then TAF-FTC for receptive vaginal sex, those studies are being done, and hopefully we'll have those data. I think the FDA was critical of the application because it did not include cisgender women, and I think that statement of except for receptive vaginal sex was a reflection of that critique of the studies.
Great. And as I understand things, by the way, FDA today is looking at Paxlovid approval, so stay tuned to the news tonight. Thanks, Hyman, so much.
Great, thank you.